Welcome to the lecture on gastrointestinal and urologic emergencies. Students who complete this chapter presentation, as well as all related coursework, will understand the concept of the following: anatomy and physiology of the gastrointestinal system, genitourinary and renal systems. Students should be able to assess and manage various patient populations with numerous related GI/GU complaints, some of which include but are not limited to direct or referred abdominal pain, hypoglycemia, hyperglycemia, shock related to acute or chronic GI disorders, hemorrhagic disorders, peritonitis, and complications related to the renal system, such as renal dialysis. Regarding medicine, you will apply fundamental knowledge to provide basic emergency care and transportation based on assessment findings for a patient who is acutely ill. Regarding abdominal and GI disorders, you will understand the anatomy, presentations, and management of shock associated with abdominal emergencies, and this includes GI bleeding. You will also have an understanding of the anatomy, physiology, pathophysiology, assessment and management of acute and chronic GI hemorrhage, peritonitis, and ulcerative diseases. Regarding genitourinary and renal, you will understand blood pressure assessment in hemodialysis patients, anatomy and physiology, pathophysiology, and assessment and management and complications related to dialysis, and urinary catheter management, as well as kidney stones. Abdominal pain is the most common complaint that we see. As an EMT, you do not need to determine the exact cause of the pain, but you should be able to recognize a life-threatening problem and act swiftly in response. The patient in pain is probably anxious, requiring your skills of rapid assessment and emotional support. Table 16-1 has some common abdominal conditions in the localization of the pain. This is a great reference for you. The abdominal cavity contains solid and hollow organs that make up the GI system, the genital system, and the urinary system. Solid organs include the liver, the spleen, the pancreas, the kidneys, and in women, the ovaries. Any injury to a solid organ can cause shock and bleeding. Hollow organs include the gallbladder, the stomach, the small and large intestines, and the urinary bladder. If there is a breach into a hollow organ, the contents will leak and contaminate the abdominal cavity. Here's a picture just describing and showing you the locations of the solid organs and the hollow organs. The GI system is responsible for digestion process. Digestion begins when food is put in the mouth and chewed. Salivary glands secrete saliva and begin to break food down, and it is then swallowed, which travels down the esophagus to the stomach. The stomach is the main organ of the digestive system, and gastric juices break down the food. The liver assists in digestion. It secretes bile, which aids in the digestion of fats, and it filters toxic substances produced by digestion. It creates glucose stores and produces substances necessary for blood clotting and immune function. The gallbladder is a reservoir for bile. Food then travels to the small intestine, consisting of three sections: the duodenum, where digestive juices from the pancreas and liver mix together. The pancreas secretes enzymes that breaks down starches, fats, and proteins. It also releases amylase, which is responsible for breaking down starches into sugar. Bicarbonate is also produced in the pancreas, which neutralizes stomach acid in the duodenum, and insulin is also produced, which regulates the amount of glucose in the bloodstream. The jejunum plays a major role in absorption of digestive products. It does much of the work in the small intestine. And the ileum is where soluble molecules are absorbed into the blood, and proteins, fats, and starches are reduced to amino acids, fatty acids, and simple sugars. The colon, or the large intestine, food is not broken down and used. It moves into the colon as waste. Movement, called peristalsis, moves the waste matter through the intestines, and water is absorbed and stool is formed. It passes through the rectum to the anus and is defecated. The spleen is located in the abdomen but has no function within the digestive system. It is part of the lymph system. It plays a significant role in relation to red blood cells in the immune system, and it assists in the filtration of blood. It aids in the development of red blood cells and serves as a blood reservoir, as well as produces antibodies. The genital system. Abdominal space also holds reproductive organs. The male reproductive system consists of the testicles, the epididymis, the vas deferens, the seminal vesicles, the prostate gland, and the penis. The female reproductive system consists of the ovaries, fallopian tubes, uterus, cervix, and vagina. The urinary system controls discharge of waste materials filtered from blood by the kidneys. The kidneys are solid organs, and the ureters, bladder, and urethra are hollow organs. The body contains 2 kidneys, one on each side. They lie on the posterior muscular wall of the abdomen behind the peritoneum in the retroperitoneal space. They play an important role in the regulation of acidity and blood pressure, and they rid the body of toxic waste. They control the balance of fluids and electrolytes, and blood flow is high in the kidneys. The ureters join each kidney to the bladder, and they are small, hollow muscular tubes. Peristalsis, a wave-like contraction of smooth muscle, occurs which moves urine into the bladder, and the bladder is located immediately behind the pubic symphysis. The bladder empties to the outside of the body through the urethra, and the male urethra passes from the anterior base of the bladder through the penis, and the female urethra opens at the front of the vagina. Normal adult forms 1.5 to 2 liters of urine per day. The abdominal cavity is lined by a membrane called the peritoneum. It also covers the organs of the abdomen. The parietal peritoneum lines the abdominal cavity, and the visceral peritoneum covers the organs. The presence of foreign material like blood, pus, bile, pancreatic juices, and amniotic fluid can irritate the peritoneum, causing peritonitis. The term acute abdomen refers to a sudden onset of abdominal pain, and it is often associated with severe progressive problems requiring medical attention. Peritonitis, which is an inflammation of the peritoneum, usually causes ileus. Ileus is paralysis of muscular contractions that normally propel material through the intestine. The retained gas and feces cause abdominal distension, and the stomach can only empty itself by vomiting or emesis. Peritonitis is associated with nausea and vomiting, and also associated with loss of bodily fluid into the abdominal cavity. To gauge the degree of distension, simply look at the patient's abdomen. Pulse and blood pressure may change significantly, and look for signs of shock. Diverticulitis, inflammation of abnormal pockets at weak areas in the lining of the colon, left lower quadrant pain, and substantial elevation in temperature. Cholecystitis is an inflammation of the gallbladder, and you have right upper quadrant pain and a substantial elevation in temperature. Acute appendicitis is where the right lower quadrant pain and the patient's temperature may be normal. There are 2 different types of nerves that supply the peritoneum. Abdominal pain can have different qualities. The parietal peritoneum is supplied by the same nerves that supply the skin of the abdomen. It can perceive pain, touch, pressure, heat, and cold, and can easily identify and localize a point of irritation. The visceral peritoneum, however, is supplied by the autonomic nervous system, and the nerves are far less able to localize sensation, and patients will not be able to exactly describe where the pain is, and we call this referred pain. So, for example, with the gallbladder, we sometimes have synapse points that move pain up into the right shoulder. Ulcers. The protective layer of mucous lining erodes, allowing acid to eat into an organ. Peptic ulcers are usually the result of H. pylori infection, chronic use of NSAIDs, alcohol, and smoking. If the erosion is severe, it can lead to gastric bleeding. Peptic ulcers affect men and women equally, but occur more frequently in the elderly population, and the pain is described as burning and gnawing, usually in the upper abdomen, that subsides or diminishes after eating. Nausea, vomiting, belching, and heartburn are common, and some ulcers will heal without intervention. Gallstones. The gallbladder is a storage pouch for digestive juices and liver waste. Gallstones may form, and if the blockage does not pass, it can lead to severe inflammation of the gallbladder called cholecystitis. This is a condition in which the wall of the gallbladder is inflamed, and it can rupture. It presents as a constant severe pain in the right upper mid-abdominal region and may refer to the right upper back, flank, or shoulder. The symptoms may appear 30 minutes after a fatty meal and at night, and these symptoms include nausea, vomiting, indigestion, bloating, gas, and belching. Pancreatitis is an inflammation of the pancreas. It's caused by obstructing gallstones, alcohol abuse, or other diseases. Some signs and symptoms include severe pain in the upper left and right quadrants, which often radiates to the back, nausea and vomiting, abdominal distension, and tenderness. Sepsis or hemorrhage may occur, and you should look for signs of fever or tachycardia. Appendicitis is an inflammation or infection in the appendix. It can cause the tissues to die, causing an abscess, peritonitis, or shock. The pain starts out more generalized and dull, but it later localizes to the right lower quadrant. Your patient may complain of nausea and vomiting, anorexia, fever, chills, and rebound tenderness. This is the result of peritoneal irritation, and we assess this by pressing down gently and firmly on the abdomen, and the patient will feel pain when you release the pressure. GI hemorrhage. Bleeding. This is bleeding caused within the GI tract, and it can be acute, which may be shorter term and more severe, or chronic, which may be of longer duration and less severe. All complaints should be considered serious, and it can occur in the upper or the lower GI tract. The bleeding in the upper GI tract occurs from the esophagus to the upper small intestine, and lower GI bleeding occurs between the upper part of the small intestine and the anus. Esophagitis. This occurs when the lining of the esophagus becomes inflamed by infection or acids from the stomach. In worst cases, bleeding can occur from the capillary vessels within the esophageal lining or the main blood vessels. Your patient may report pain in swallowing. Some additional symptoms include heartburn, nausea, vomiting, and mouth sores. Esophageal varices occur when the amount of pressure within blood vessels surrounding the esophagus increases. When blood is blocked up the portal vessels, vessels dilate, causing the capillary network of the esophagus to begin leaking. Initially, the patient will show signs of liver disease, such as fatigue, weight loss, jaundice, anorexia, edema in the abdomen, abdominal pain, nausea, and vomiting. This is a gradual disease process, and it can take years before the patient becomes uncomfortable. It is far more common for there to be a rupture of the esophageal varices, and it's sudden. The sudden onset of discomfort in the throat, severe difficulty swallowing, vomiting bright red blood, hypotension, and signs of shock. Mallory-Weiss syndrome. The junction between the esophagus and the stomach tears, and this causes severe bleeding and possible death. Primary risk factors are alcoholism and eating disorders. It's prevalent in older adults and older children, and vomiting is the principal symptom. In extreme cases, patients may experience signs and symptoms of shock, upper abdominal pain, hematemesis, and melena. Gastroenteritis. This is an infection combined with diarrhea, nausea, and vomiting. It's caused by both bacterial or viral organisms, and they enter the body through contaminated food or water. Diarrhea is the principal symptom in both types, and the patient may experience large dumping-type diarrhea or frequent small liquid stools. It may contain blood or pulse. There may be abdominal cramping, nausea, vomiting, fever, and anorexia. Diverticulitis. Diverticulitis was first recognized around 1900 when the amount of processed foods eaten increased. The consistency of stools became more solid, requiring more intestinal contractions, increasing pressure in the colon. Bulges in the colonic walls result from increased intestinal contractions, and fecal matter is caught in the bulges and bacteria form, causing inflammation and infection. Classic symptom is abdominal pain on the left side, lower abdomen, and the signs include fever, malaise, body aches, chills, nausea, and vomiting. Hemorrhoids are created by swelling and inflammation of blood vessels around the rectum. It may result from conditions that increase pressure on the rectum or irritation of the rectum, and increased pressure may be caused by pregnancy, straining for stools, and chronic constipation. Diarrhea can also irritate hemorrhoids. Generally, these present as bright red blood during defecation, and it's minimal bleeding and easy to control. The patient may also experience itching and a small mass on the rectum. The urinary system. Cystitis, or a bladder infection, is common, especially in women. We also call this a UTI. It is a bacterial infection, and patients will usually have lower quadrant abdominal pain. They may also report an urgency and frequency in urination, and it can become a serious problem if infection spreads to urethra or kidneys. The kidneys play a major role in maintaining homeostasis. They eliminate waste from the blood, and when the kidneys fail, uremia results. The waste product, urea, remains in the blood. Kidney stones can grow over time and cause blockage, and these are crystallized chemicals in the urine, and blockage can lead to swelling, and the pain is caused by the stone moving within the ureter. The stone may pass on its own, or it may have to be surgically removed. Acute kidney failure. This is a sudden decrease in function, and it occurs from hemorrhage, dehydration, trauma, shock, sepsis, heart failure, medications, drug abuse, and kidney stones. It is reversible with prompt diagnosis and treatment. Chronic kidney failure, on the other hand, is irreversible. It's progressive and develops over months and years. It is often caused by diabetes and hypertension, and the kidney tissue shrinks and function diminishes. Eventually, the patient will require either dialysis or transplant to remove the waste from the bloodstream. The symptoms include altered levels of consciousness, seizure, coma, lethargy, nausea, headaches, cramps, and edema in the extremities and face. Female reproductive organs. Gynecologic problems are a common cause of acute abdominal pain. Lower quadrant pain may relate to the ovaries, fallopian tubes, or the uterus. In Chapter 21, we'll talk about these in depth. Other organ systems. The aorta lies immediately behind the peritoneum. Weak areas can result in an abdominal aortic aneurysm, also called a AAA. AAAs are difficult to detect, and you might feel a pulsating mass in the abdomen, but there's no guarantee. Pain may be described as tearing, and you should use extreme caution when you're trying to assess or detect these. Aneurysm development is slow, and if it tears or ruptures, massive hemorrhage will occur. Pneumonia, especially in the lower lungs, can cause ileus and abdominal pain. Hernias can also occur. A hernia is a protrusion of an organ or tissue through a hole or opening into a body cavity where it does not belong. They can occur as a result of the following: a congenital defect, such as around the umbilicus, a surgical wound that has failed to heal properly, a natural weakness in an area, such as in the groin. Hernias may not always produce a noticeable mass or lump. Reducible hernias pose little risk and can be pushed back into the body cavity. Incarcerated hernias cannot be pushed back in and are compressed by surrounding body tissue. Strangulation of an incarcerated hernia is a serious medical emergency because the blood supply is compromised by the compressed surrounding tissue. Some serious hernia signs and symptoms include a formerly reducible mass that is no longer reducible, pain at the hernia site, tenderness when the hernia is palpated, and red or blue skin discoloration over the site of the hernia. Patient assessment. The steps are always the same. We're going to size up the scene, perform a primary assessment, take our history, perform a secondary assessment, and reassess. We always need to ensure scene safety and use standard precautionary gloves and eye protection. We should consider donning a gown and covering your shoes with disposable protective covers. We need to evaluate the mechanism of injury or nature of the illness, as we also need to understand that an acute abdominal issue can be the result of violence, such as blunt or penetrating trauma. We need to always be vigilant, and we will talk about traumatic abdominal injuries in Chapter 28. A pale or sweating patient who reports tearing pain may be having a AAA. We also need to remember that GI bleeding often has a characteristic odor. Primary assessment. First priority for any of our patients is that we as EMTs identify and treat life threats. We want to assess level of consciousness and assess airway, breathing, and circulation. The patient will often have knees drawn up to ease the pain of the abdomen, and we need to consider necessary treatment and transport options. We need to form a general impression. Ask the patient about their chief complaint and include AVPU in your assessment and general impression. Airway and breathing. Abdominal pain may cause shallow, inadequate respirations, and you may need to treat for this. Ask the patient about blood or vomit or black tarry stools. And remember, pulse rate, quality, and skin condition may indicate shock. We want to check pulses in both arms because it may indicate an aneurysm if there is a difference. Shock may be caused by hypovolemia or be the result of infection. If shock is present, intervention should include high flow oxygen, elevation of the patient's legs, keeping the patient warm, and all of these things are important. Make your transport decision. Immediate if signs of significant illness are present, such as pale, cool, diaphoretic skin, tachycardia, hypotension, or altered LOC. Ensure that the ride is gentle, smooth, and steady. Take your history. Investigate your chief complaint and remember that this is often based on previous history or of chronic medical problems. Consists of subjective and objective observations. The sample history addressing the following areas such as nausea and vomiting, bowel habit changes, urination, weight loss, belching or flatulence, pain, other signs and symptoms, and concurrent chest pain. Perform a secondary assessment. This may be performed at the scene or in the back of the ambulance en route to the hospital. Time may not permit a secondary assessment if you have to manage life threats identified during your primary assessment. Positioning of the patient may give you clues as to the nature of the illness. If the patient has an appendicitis, they may draw their right knee up, or a patient with pancreatitis may lie curled up on one side. Perform your physical exam. A normal abdomen is soft and not tender to the touch. Pain and tenderness are most common symptoms of the acute abdomen. Localized pain may give clues to the problem organ, and muscles of the abdominal wall may become rigid involuntarily. This board-like muscle spasm is called guarding. The following steps will help you in your abdominal assessment. Explain procedures to the patient. Place the patient in the supine position with legs drawn up and flexed at the knees. Expose and visually assess the abdomen. Ask the patient where the pain is most intense. Palpate the abdomen very gently. Gently palpate all 4 regions of the abdomen to determine softness or guarding. Note whether the pain is localized or widespread. Look for patient response after palpation. Determine whether the patient exhibits rebound tenderness, and determine whether the patient can relax the abdominal wall on command. Guarding and rigidity may be detected during the physical exam. Take vital signs. An elevated respiratory rate with a normal heart rate and blood pressure may indicate improper ventilations. An elevated respiratory rate and pulse rate with signs of shock may indicate septic or hypovolemic shock. Use monitoring devices like pulse oximetry and non-invasive blood pressures. Reassess. Because it is often difficult to determine the cause of abdominal pain, frequent reassessment is important. Has the patient's level of consciousness changed? Has the patient become more anxious? Have the skin signs begun to change? Has the pain gotten better or worse? Has bleeding become better or worse? Is current treatment improving the patient's condition? Has an already identified problem gotten better? Has an already identified problem gotten worse? What is the nature of any newly identified problems? Assess interventions, including treatment for shock, and provide emotional support. Transport the patient in the most comfortable position, and most patients will want to be on their side with their knees drawn up. And consider the need for ALS support. Communicate with the receiving hospital early to allow the staff to recruit resources necessary to treat your patient upon arrival, and carefully document your findings in your patient care report. Although you cannot treat the causes of acute abdomen, you can take steps to provide comfort and lessen the effects of shock. Treat the patient for shock even when obvious signs of shock are not apparent. Position patients who are vomiting to maintain their airway. Contain the vomitus to prevent spread of infections by using a biohazard bag. Wear gloves, eye protection, and a gown. When the patient has been released to hospital staff, clean the ambulance and equipment. Wash your hands even though you were wearing gloves, and provide low-flow oxygen, and this will often decrease nausea. Elevate the patient's leg to facilitate blood flow. Kidney dialysis. In chronic cases of kidney failure, dialysis is the only definitive treatment. Dialysis is a process that filters the blood, cleanses it of toxins, and returns it to the body. It eliminates waste, normalizes blood chemistry, and reduces excess fluid. If a patient misses a dialysis treatment, weakness and pulmonary edema can be the first in a series of conditions that become progressively more serious. Some services transport patients to and from dialysis centers. A dialysis machine functions much like normal kidneys do. If a patient is undergoing long-term hemodialysis, they will have a shunt that connects a vein and an artery, allowing blood flow from the body to the machine. Peritoneal dialysis allows large amounts of dialysis fluid to be infused into the abdominal cavity, and the fluid stays there for an hour or two. It does carry a high risk of peritonitis. Some adverse effects of dialysis include hypotension, muscle cramps, nausea and vomiting, hemorrhage from the access site, and infection at the access site. It's important to remember that many dialysis patients will also have urinary catheters, and they can often be the site of infection. In summary, an acute abdomen is a term used to describe the sudden onset of abdominal pain that is not caused by a traumatic injury. The pain, tenderness, and abdominal distension associated with an acute abdomen may be signs of peritonitis. In addition to abdominal disease or injury, problems in the GI, genital, and urinary systems may also cause peritonitis. Signs and symptoms of the acute abdomen include pain, nausea, vomiting, and a tense, distended abdomen. Pain is commonly directed over the inflamed area of the peritoneum. or it may be referred to in another part of the body. Do not give the patient with an acute abdomen anything by mouth. A patient in shock or with any life-threatening condition should be transported without delay. Call for ALS rendezvous if the patient's condition deteriorates during transport. Thanks for your attention, and as always, bring questions to class.